Hey everybody. If everyone could kind of find their way back to their seats, we're going to get started with the next session. So again, I'm Graham Brady, junior faculty hepatologist at the University of Michigan. I'm happy to be a part of this. And I will be the moderator for this session, which will be kicked off by Dr. Matthew Lorenz, who is a co-director of the Wilson Disease Center of Excellence here at the University of Michigan, and we'll be talking about neurological symptom improvement in Wilson disease.
Thank you very much for the introduction, and thank you everybody for being here today and the invite. Myself, I like to start with a case study because I think for me, as I've been going through this over many years in our Wilson's disease clinic, I've learned, and I don't want to discount Fred's importance here, but I've learned so much about Wilson's disease from the patients, what they've taught me, how to treat the disease. And so this wonderful person, like I've been able to interact with over many years now, is a kind of a great example of many of the things we've already talked about for Wilson's disease. So a young person, but not too young, 21 years old, kind of typical of the age range of neurologic Wilson's disease. First with anxiety and depression that was new onset. And so we heard about the mental health aspects of it, how unrecognized it probably is as a first presentation, got treated for that with medications and developed a disorder, which progressed over 6 to 8 months and then became much more than what you might expect as a medication side effect. This led to her primary physician or the primary physician getting a brain MRI, and you can see, I don't think I have a pointer, but just these for people kind of initiated, all these white spots areas are very abnormal. That's the basal ganglion region. And although the person who was treating her was not thinking about Wilson's disease at all, once they got the MRI, they said, oh, maybe this is Wilson's disease, and so that's great. We have a pretty common, readily accessible test that can kind of cue you to, is this Wilson's disease? And so then typical workup went on, very elevated urine copper, as you can see there. And then also we talked about ceruloplasmin, which was low, and then also the eye manifestations, which you've heard about, the Kaiser-Fleischer rings, which were identified. So a very, very typical presentation of Wilson's disease. It took quite a long time to actually identify and get treatment going. Local physicians started a very typical medication at a very reasonable dose, but unfortunately, this patient had a very precipitous decline. And so basically so much so that she really could only blink her eyes, almost completely being locked in. And that's when I think Dr. Ascari and I basically first met her. So I think some takeaway points that I've already kind of gone over. Think about psychiatric manifestations as the first manifestations. Delayed onset of diagnosis is extremely important, extremely common, which is a real problem in Wilson's disease in general, because that usually results in a delay in treatment. Luckily, we have some tests that can point us in the right direction. Fortunately, pretty common that people get a little bit worse after we make the diagnosis before we can get things under control. And then from a neurologic perspective, the thing that I have been very concerned about and very much interested in making sure we don't cause is this precipitous neurologic decline with initiation of treatment or severe decline as treatment becomes effective. So in this individual, so symptom improvement, which is what I have been sort of focusing on here. And so I think the good message is that most people with Wilson's disease, once they're treated, do much better in general and neurologically, but it takes time. And so that's one of the problems. And so in this case, copper control for a year, which is a pretty long time to have copper control. She was still severely impaired. Couldn't walk, really could hardly speak, still needing a PEG tube. For 2 years, continued improvement, was able to walk without a walker, able to now swallow, but still using a peg tube for some cases, but really clearly better than she was, but still very neurologically impaired. And so skip ahead even further, 4 years later when she comes to clinic. Now she comes into clinic and shows me that she can run in the hall. She's returned to snow skiing, and she really has mild non-limiting dystonia. And so this is an amazing example of symptom improvement in Wilson's disease, and one that I think everyone who cares for Wilson's disease should have in mind, so that if you see someone who's very neurologically impaired, don't discount that. There's hope. And so, but we have to have, potentially better treatments. And so she has been also very instrumental in helping us as both a patient and then as a subject in our clinical trials. And she entered into the Alexion 1840 clinical trial. So I just wanted to go over some of these questions. I'm not going to address them all, but I think there are questions that have already come up a little bit, just sort of some outstanding issues that we need to think about in the field of Wilson's disease in general. So diagnostic delay, how can we do better with that? What's the best choice for initial treatment? We have some gestalts about why we do the things we do. We certainly don't have clinical trials that help us with that. How do we avoid this severe neurologic worsening? How long should we tell patients that they need to wait to know how much better they're going to be from when we first meet them? In general, we have said in the past, my guidepost had been, after about 18 months to 2 years of very good control, that's probably about where you're going to be. But the last couple of years has changed my mind on that. I don't think that's right. I think that people can actually get better much longer outside that window. And then other things, what else can be done during recovery to optimize recovery? We focus on copper, I think rightly so, but we've also focused on other things like mental health, physical therapy, all these other things, social support that can help people improve both symptomatically and in their daily function and in society through their journey through Wilson's disease. Talked about mental health, and then what's the strategies for this long-term copper control. So a lot of questions. I don't have time to go through all of them, so I'll focus on the ones we have the best science for. And so I just wanted to take you through just a couple of slides. We've heard of this, basically the tetrathiomolybdate. We've been involved in this. George Brewer, as we've heard about, instrumental in zinc therapy, but also instrumental in thinking about tetrathiomolybdate. It has a little bit of a different mechanism than the other agents. And we think it also pulls the copper out of the tissue, but in a way that doesn't cause this excess free copper that can cause the neurologic worsening. I'm not going to go through it in a lot of detail, but just mechanistically what we see with the copper is it does well. So it mobilizes copper compared to standard of care. It seems to start to work relatively fast. When we follow it, it continues to work. And it also works both in patients who have never been treated with for Wilson's disease, but also those who have been treated over a long period of time. And so some of these, I think a lot of you have been involved in these Alexion 1840 or TM trials. And it's a little bit of a sad story, at least for now. I'm hoping it'll have a happy ending. But I think what we're in the phase of now is trying to learn as much as we can from that trial. And so I think one of the things that I've already mentioned is that the 1840 showed that basically you can have improvement in the neurologic part of Wilson's disease. And so this graph, the red line shows the people who were on standard of care, and then the purple line is those who were treated with 1840. The red line ends at 48 weeks when people were allowed to cross over to 1840. And what it shows is that people improved over standard of care and improved over a long period of time, and that endpoint is 6 years. And so those are people who are on standard of care for up to 10 years. And so those people got better with the new therapy, which we didn't think was a surprise. And we're still digging into these data. And so it's great to have improvement on a UWDRS rating scale, but as a clinically significant. And when individuals have done analysis, it turns out that the changes that people had were clinically significant. And so and those clinically significant differences persisted again over time. And just the two different parts, the UWDRS rating scale, part 2, which I didn't say, is patient report, and part 3 is what the neurologists see on their exam. So we've also talked about the psychiatric part, and for me, the psychiatric part of it is really important, because I think one of the things that really has a tendency to take patients off the rails of their life is the psychiatric part of it, even after they have good copper control, especially the executive dysfunction. And I've seen a lot of examples of that in patients who things are going pretty good, but they have a lot of trouble with executive dysfunction. And so what that means is they make bad decisions. They do things like shoplift. They do things like drive a car when they shouldn't be driving a car, and so they get in trouble. And that's a problem. Fortunately, we also saw improvement with psychiatric symptoms with the 1840. So as one of the real problems with the medicines we have is that they have toxicities. And so the 1840 also showed pretty good signal in that. Well tolerated, some liver enzyme abnormalities, which you can expect. But from my perspective, which is why I think we need better treatments for Wilson's disease, is this agent doesn't really show neurologic worsening. And that's the thing that when we see this in clinic, people get worse when they're either when you first start them or when they're on treatment for whatever reason. That's the thing that's really devastating, and I think it's an area of improvement for sure. And patients generally liked it, and that really came to light when the trial ended, when AstraZeneca ended the trial, and how upset our patients were to have to come off the agents. And Ashley is the one that can really tell you that. And it also demonstrated that maybe some of that persistent improvement was really, it was really because of the medicine, because when we switched people back to other agents, they often worsened, and that was incredibly sad to see. Fortunately, another company, Monopar, is taking it up. We'll see if they can push this agent over the finish line to get it FDA approved, so our patients can take advantage of it. So just in general, traditional therapies work, so that's great, but there's areas for improvement. I think that the other thing that I wanted to emphasize is that we should really continue to provide hope for people who are on agents for a long period of time, that there's areas for improvement even after they've had long copper control. And as we'll hear about, there are a lot of new agents, and the idea is that those will fill some of these gaps. So again, I wanted to thank everyone today, and people who invited me, and everyone who's come.
Thanks, Matt. That was awesome. The next talk is going to be by Dr. Fred Ascari, who's also co-director director of the Wilson Disease Center of Excellence, and is going to continue the theme of talking about clinical trials in Wilson disease.
Thank you, Graham, and that's a wonderful lead-in. Obviously, I'd just like to throw up a few disclosures. These are companies that we receive research funding from, research support, so we always like to make people aware of that. So how close are we? Clinical trials are underway with gene replacement strategies with ATP7B AAV vectors on multiple contents with multiple sponsors. So clinical trials are anticipated to start with gene correction strategies literally in the coming weeks. We keep saying that. It's stretching out a little bit with the paperwork, but it'll be really soon. So what are some of the indications for gene therapies for Wilson disease? Well, it depends on the clinical trial results and improvement in symptoms and side effects. Potential indications would be incomplete symptom control or response to standard of care, intolerance or non-adherence to standard of care, and a desire to improve outcomes. So gene therapy holds the promise of improving patients' lives and outcomes, but remains to be seen if we meet those challenges. So there are 3 ATP7B human gene therapy studies. One is with a company called Ultragenyx that's ongoing. The phase 3 study is pending approval. We've completed 4 cohorts of treatment with different doses and immunosuppression strategies, and the data from the 4th cohort is undergoing analysis. There's another company called Lingyi Biotech, which is ongoing as far as I know. It's in China. It's a Chinese company. They've presented at international meetings. And then Vivet was the 3rd company that terminated at low doses with some gene transfer and infusion reactions. So basically, those are the landscape of these gene correction trials. So these are basically gene addition trials. So you're basically taking a vector, which is a hollowed out virus. It doesn't have the viral information in it to replicate, but it's just taking the coding. It's kind of like a Trojan horse, and we're putting ATP7B gene in it, and then it's getting into the liver cells. So it's being infused. And how does that work? Well, here's an illustration of an AAV infusion that for an FDA-approved treatment for hemophilia. So there you see it's basically an IV bag, and it's introduced through a vein, peripheral vein, and infuses over a period of a few hours, and then the gene goes to the liver. And here we see the factor 8 or factor 9 being produced and excreted into the body. So that's already clinically available and FDA approved. So the idea is to try and do a similar thing for Wilson disease. So here in this Ultragenics, the phase 1/2 portion of the Cypress trial, 15 patients were dosed in 3 cohorts, and then we have an additional 5 additional patients dosed in a 4th cohort with more immunosuppression. And so there are different types of AAV. This is an AAV9 vector dosing. And the greatest efficacy was seen in the highest dose in some but not all patients. And expression was demonstrated by in situ hybridization, which is a slide illustrating it with the little dots there, immunohistochemistry, and as well as some biochemical markers. So here's another example of a baseline in week 52 liver biopsy, which basically on the left side of the slide, you see the normal brown stain with the canalicular ATP7B, and you can see on the baseline on the left, there's not much of that brown activity, and you see it increases in the 52-week slide. So again, in these studies, we're seeing some increased gene expression. This is with antibodies to ATP7B. So in summary, the immunochemistry demonstrates novel expression, and it localizes correctly the bile canaliculi. So not just that it's being expressed, but it's also being expressed in the right place. Transgene expression is confirmed by in situ hybridization, so using multiple methods to demonstrate gene expression. And here, coming back to that question about ceruloplasmin, with the gene therapy, we see correction with increases in ceruloplasmin in some of the patients. In this study, 7 out of 15 people discontinued their standard of care by week 52. I might add, though, that this may not be the optimal endpoint, because you may have a benefit even if you have to stay on treatment. So they were patterned that after the FDA approval of the hemophilia gene therapy, where people discontinued infusions of clotting factors. But that may not be the right thing for this disease. We may have people continuing on their treatment, which raises other issues. Patients who discontinued their standard of treatment maintained stable non-ceruloplan bound copper throughout the 52 weeks. And most of the subjects in these first 3 cohorts reported feeling better. Cohort 4, with more immunosuppression, is being analyzed. The more immunosuppression leads to more side effects from the immunosuppression, but fortunately that's reversible. So longer-term follow-up, beyond a year, is obviously eagerly anticipated. How well does this work? Is it going to work for everyone? Can it be used effectively? So, so it appears to have worked, but not equally well for all patients. And cohort 4 was a lot of pretreatment with immunosuppression, Rituxan, 2 doses of Rituxan, which depletes antibody-making cells, prednisone and tacrolimus to mitigate immune responses, and obviously those of us who prescribe tacrolimus knows it causes tremor, and so that can be a transient problem with that for Wilson's patients. Fortunately, reversible. So in terms of gene, when they come off the drug, in terms of gene editing, there are efforts to repair the genetic defect. you can count, depending on how you want to count mutations, it can be quite a number. There are a lot of mutations that we're not certain if they're causing disease or not. But here we're going after the most common ones. The company is Prime Medicine, going after the H1069Q and the R778L. And here the idea is if you can turn someone who's affected into a carrier, you'll have a benefit because the carriers are fine. So, even though you're only maybe fixing 50% of their genetic defect, if they're not homozygous for those mutations, it still may work. So prime editors are repair broken genes in patient cells. They basically involve a protein, a reverse transcriptase Cas protein, or reverse transcriptase protein, and a RNA template and a delivery system. So the idea is you basically go in and correct the broken instructions in the gene, and they can also remove base pairs and add base pairs. And in theory, they could be programmed to treat every one of those Wilson disease mutations. So if you get it to work for the two most common mutations, could you go back and get it to work for other ones? So the prime editing trial is, basically involving an IV infusion, and this is a lipid nanoparticle with those prime editing proteins and RNA template in it. And so gene replacement and correction therapies are advancing in clinical trials. Challenges include pre-existing AAV subtype antibodies to vectors, side effects of immune conditioning regimens, immune responses to delivery vectors, longevity of gene expression, and gene mutation targeting, since there's so many. So how close are we? We may well have one or more approved gene therapies for Wilson disease in the coming years. I don't know. It depends on the results of the trials. It will likely not work for every Wilson patient due to pre-existing antibodies or only targeting a few gene mutations. And then there may be access issues, too, of insurance companies paying for it, particularly if it doesn't allow the patient to come off their standard of care meds. So it really remains to be seen how close we really are, but it's exciting that this is being studied. I want to shift gears now and mention Orphalon. Basically, they have a trial upcoming for trientine versus penicillamine for initial therapy. The trientine is only approved as a maintenance therapy, is used off-label for initial treatment, the way Dr. Lawrence described in his case. Penicillamine is the only drug approved for initial therapy, and also studying once daily dosing, which obviously would be an exciting advance. And then, Monopar has the Alexion 18-4 choline thiomolybdate. As Matt alluded to, it's kind of like the Monty Python skit. It's not quite dead yet. It's being actually feeling a lot better. It's being analyzed. Data analysis, manuscripts, regulatory filings, and follow-up studies are may be done. But at this point, there's still a lot of excitement around this drug for the reasons Matt showed in his discussion, and it remains to be seen where that goes. And then Eton Pharmaceuticals, who's representing Galzin, also is working on gentler formulations and less frequent dosing. So, and I want to touch on the Wilson's disease registry studies, a biorepository, data tracking, and of course, the Wilson's disease funds one of those studies. So there's a lot of activity in these kinds of observational clinical trials too. I'm not just talking about therapeutic, and interest in other diagnostic tests too. So I want to acknowledge the meeting organizers, the WDA host, the meeting sponsors who are in your, program, and then obviously the numerous collaborators. Obviously, these clinical trials wouldn't occur without many different people, and I try to encompass everyone here. And then I have to mention people we've received research funding from, who are the sponsors on the bottom. So thank you to everyone who's involved in these studies. And so with that, we'll switch gears, and Graham can introduce our next speaker, who many of you know is instrumental in the clinical trials.
Thanks, Fred. That was fantastic, and sort of a tour de force on where things are at the moment with exciting therapies. I do want to remind people, again, there will be a Q&A session after this group of talks, so please do write down your questions. You'll have a chance to ask them in a few minutes. Next, as Fred mentioned, Ashley Page, who is one of our clinical research coordinators, and people may know her already, will be talking about sort of the system and the team that is involved in running, participating in, and performing a successful clinical trial.
Thank you for that great introduction. I'm Ashley Page, a research coordinator with the University of Michigan. I've been a part of the Wilson's disease clinical trials since 2020. And kind of to echo what Dr. Lorenz had said, I think I've learned most from the patients, learning your stories with your diagnoses, your journey with treatment options, and really the desire to contribute more data to the community. So today I'll talk a little bit about the importance of clinical research with Wilson's disease. Really, what is clinical research, and what it takes to consider whether or not participating in the trial is right for you. So why it's critical in rare disease. Oftentimes with rare diseases, we have smaller populations of people, so it takes longer to collect the data. We've seen with COVID-19 trials, it affected so many people that they were able to compile data pretty quickly, but that's not really the case with Wilson's disease research, especially with patients traveling from a great distance to see their providers. They may not know where trials are being conducted, and really the importance is to help better monitor Wilson's disease, provide a better understanding of the neurological and psychiatric symptoms, and ways to reduce the daily burden with your disease, and really to bring hope for the future and future patients. So clinical research involves carefully designed trials and studies with people to help improve and prevent the diagnosis and treatment of different diseases. Participation is completely voluntary. It's really protected under strict rules, a lot of ethical guidelines that go into place that were built on the foundation of past trials that may have not been conducted in the most ethical manner, and then really making sure that you have all the correct information to decide whether or not participating is right for you. It doesn't replace standard of care, but it runs alongside your routine care and prioritizing safety and patient autonomy. So there's a number of people that are involved in making up a clinical trial. There are pharmaceutical companies that develop the drugs, often are a funding source for the clinical trial, investigators at different research centers, research organizations that monitor the data that's being collected, submitting that data to the trials, patient advocacy groups, or patient support groups. So helping navigate travel or travel assistance so that you're able to come to your clinical appointments, institutional review boards, making sure that the research is being conducted in an ethical manner, and then kind of where I come in as a research coordinator, serving as the lines of communication between all these stakeholders in the clinical trials. So I'm often the main point of contact for patients, kind of relaying information to you about a clinical trial, taking your feedback back to pharmaceutical companies, sharing your concerns or what you would like to see in a clinical trial, communicating to you what is being conducted in a clinical trial, the treatment options, the visits that are involved, the assessments that are being conducted, what are the costs to you, how can I help make that decision process a little bit easier for you. Then also advocating, so listening to your concerns, giving you honest answers, or seeking out that information, really to help support your decision, and then reminding you that whether or not clinical research is right for you, there's no judgment involved. You're able to change your mind if that is what is best for you, and then it really is built on communication and trust and respect, so that participants feel supported, and hopefully I can help minimize some of that overwhelmingness that is involved with deciding whether or not you are interested in a clinical trial. So it is a big decision, and there's a lot that goes into determining whether or not clinical research is right for a participant. And oftentimes someone may join just out of the hope that there's access to new treatment options that aren't widely available yet. Some may feel comforted by the fact that there are additional visits involved. So you might see your provider on a regular basis, maybe 1 to 2 times a year, but within a clinical trial, we're seeing you more regularly. So someone's watching you a little bit more closely. You're having a little bit of more additional labs that are being conducted. And then you may feel that with that extra monitoring, improved adherence with your treatment options. And then, contributing to the potential future impact of Wilson's disease, so we can help understand, the disease, the treatment options, and really beyond your personal interests. So your future children, your grandchildren, or really just to contribute any piece of data that may be helpful to the Wilson's disease community. There can be a lot of barriers to consider whether or not you want to participate. So even though we know that research can help participants, it can be difficult with time commitments, busy work schedules, school schedules, traveling to specialized centers, or just the frequency of lab tests can be disruptive to your school and work schedules, your family life, especially people who are managing lifelong conditions. With past research, you may have fears that have grown out of how previous trials have been conducted. So you might worry about some of the side effects that are involved, or even just really knowing where to seek out information. So a lot of the information could be overwhelming, or overly complicated materials make it hard to really decide if you want to participate in a trial, and then that information overload might steer you away from wanting to participate. So it just really is kind of where I fit into this mix. My role is to help you kind of be your sounding board, so whether or not you want to participate in research to begin with, breaking down the information to help you feel safe and comfortable in the overall process. Hopefully building a clear and trusting and understandable relation, or clear, building trust through clear and understandable communication, trying to help reduce the burdens of participating in a clinical trial. So I may help arrange some of your travel for your visits, making sure that you understand the costs that are involved in a clinical trial, alleviating some of that burden, to help you understand that a lot of these sponsors may provide financial support. So your hotels, your flights, the medical appointments, helping you understand what cost would be on you or the sponsor, and really to help improve the data quality in real-world reliance. So how do you get involved in clinical research? Oftentimes talking with your providers, your hepatologists, neurologists, or even your research coordinators can be a great option. There's a lot of websites that you can search online. Clinicaltrials.gov may be one. U of M Health Research is another that we often will post our clinical trials to, so you can gain some information on. And again, there is a lot that goes into deciding whether or not clinical research is right for you, and oftentimes we may not know what questions to ask, so we can't seek out all the information if we don't know what questions to ask. So these are just to give you a little bit of sounding board. So if you are considering participation in a clinical trial, maybe some questions that you can bring to your research team. So what type of trial is it? What phase of a trial is it? And why does it matter? How will it benefit me? What are the risks? What type of test or what are the costs will I have? And really, there's so many that you can consider. Do you feel rushed with the decision-making process? Is this right for me or my family? And really, clinical research is how we advance that treatment options for patients. It's always a choice. It's whether or not you decide to participate. There's no right or wrong answer. And hopefully we can progress Wilson's disease care, and which really has been made possible because of patients who have shared their time and their experience and trust with the research community. Thank you.
Thanks, Ashley. That was great. So for the last component of this morning's session before the Q&A, we will have a conversation with Dr. Fredescari from the Wilson Disease Center at University of Michigan, and then Lana, I don't know how to say your last name, Escamilla? Okay. Lana Escamilla from the Wilson Disease Association, Director of Patient Advocacy.